distributes its patients into dossiers of test results, standardized treatment protocols, and expert opinions to which they have little to contribute. Today, as a free consumer of this free market healthcare, I too am gaining a feel of what it means to be a target. Taking a leaf from an ordinary Indian's book of common knowledge, I now search carefully for medical services I could trust a little more. Maybe because I have a family connection with them, or because the doctor or even the attendant comes from my mohalla, belongs to my caste, and knows and understands my situation better. Most importantly, I look for doctors and hospitals that have some kind of oblique relationship to the current dispensation and are known for their commitment to caring for ordinary people who are their patients. I fear, like Kamala does, that this is a species that may be dying out. So that's the small experiential statement. The key point that I'm making there is that a privileged position that I had earlier on as maybe an urban elite person who had some control of the consumption of medicine, that key position now is being completely redistributed as I begin to feel like a target of the new medical facilities, corporate healthcare, whole body testing procedures, etc., etc., etc. A target that makes me feel much more intimately connected with the way public health programs were run in our country earlier. And this is therefore a critique both of the new system of clinical care and of the old public health programs which still continue in a new format. They're not different. What is my argument? And there are two new things that I'm saying in this essay. One is, we tend to think of clinical medicine and public health as two completely different formations. Clinical medicine is regarded as scientific, related to an individual, directed at a single body, and as embedded in a specific doctor-patient relationship. That's a one-to-one relationship. Public health, on the other hand, is a huge administrative initiative. It will be along select programs. We have very little primary health care which is holistic. Public health is along, so today we have nutrition programs, we have tuberculosis programs, we have AIDS programs. There are specific lines along with public health. And public health programs are designed to, they're a bit like eminent domain in the land acquisition discussions that we have today. They're designed to improve the health of the nation. And you're never quite sure what this nation is, because clearly the people who are being given DOTS, which is a very strong, it's a chemotherapy actually, medication for tuberculosis, are nearly all bleeding from this medication. But we all know that it will safeguard the country from tuberculosis. And so we have to think about what is this country that is being addressed in the big public health programs. So my argument is, and this is an argument from now taken also from some other scholars' work on modern medicine. The argument is that though we tend to think of clinical medicine and public health programs as completely different, actually, structurally, all medicine is a public health program. Why do we argue this? Now it's like saying nothing exists which is in the format of clinical medicine. Clinical medicine is actually dealing with a single case in what is a huge public health style program that is designed for a disease. I'll try to explain what I mean by this. If we look historically, histories of modern literally as though this is a series of inventions that have taken place and where science is advancing and that newer ideas are coming up and therefore treatments are improved. But if you look more closely and we ask ourselves, what is the structural setting? Not just what is the individual story, but what is the structural setting in which modern medicine emerges? And you see quite clearly that when you look at Europe, it is epidemic control, public health, administrative initiatives in hygiene, sanitation, the burial of the dead, the provision of water, the control of epidemics being met. This is really the cradle in which modern medicine begins to emerge. And that's, if you look 19th century, early 19th century, late 18th century, that's the period in which in huge administrative initiatives we're getting the beginnings of what are called modern medicine. There is research programs that go along as well, but you see that these research programs in malaria, programs about malaria, or cholera, or big diseases as well as ideas of nutrition and so on, come from within this administrative setting. And the overall administrative formation of medicine actually structures the way clinical medicine is transacted. What are some of the implications of this? Well, when we health activists working with medicine, a very good example is the notion of health. Alright? Nobody knows what health is. If I say to you, what is health? You can't define it. And the very fact that we can't define it leads us to think about the idea that health is not a personal attribute. Health is actually an administrative phenomenon. You look to the health of a people. So it's a set of indices, a paradigm in which you understand what medicine or medical intervention should be. So the notion of health itself is one of the most deep-set governmental notions that govern medicine or medical ideas themselves. The idea that we're talking about health of a nation, the health of a population, and so on. Now the big debate in medicine today is, or in the social debate about medicine today is, has the corporatization or the privatization of medicine actually vitiated it, has it led to some problems, or has it improved medicine? And the assumption there is that there is a total difference between the old state-invested medicine, which is what happens, the European countries have a state-financed and a state-led medical program, and many of us who are in the health activism field feel it would be wonderful for us to have a state insurance or a state-financed public health program that was available to everybody. Right? I still believe this. But the argument here, the argument I'm making in this paper is that whether it is in the corporate mode or whether it is in the statist mode, the very structure of medicine, if we look historically, and this is history in the present, is statist, it is governmental. I gave you a little bit of an example of why we, meaning the group that I'm working with, are making this argument. But you can also see the governmental format of this medicine today if you look at how medicine decides on the effectivity of a drug. So you test it out on the population and you decide whether a certain, how effective is it? There's a placebo population and there's a standardized procedure through which it's done. And there are huge medical tests. India is one of the countries where large number of drugs are tested out, procedures are tested out. We have a very big medical group of medical personnel available, and we also have a very big population available. So at the moment, we are the hotbed of all this kind of medical testing that's taking place. Now the very idea of testing out drugs, the procedures and so on and how it's done assumes the kind of relationship between the individual and the procedure that is a governmental type of relationship. These are targets, populations that you study and that you look at and that you calibrate the medicine for that target or that population. Now, if you look at how drug companies